Okay. Is that better? Yes. Okay. Good afternoon, everyone. Good to have you here. I want to welcome everybody, and it looks like we may have a quorum, and we'll decide that in just a second. But I want to thank everybody for all the hard work that's been going on prior to this second meeting. I have to say, I know how much because I've seen and tried to attend all the subcommittee work group that have attended and know that everybody is really doing great work. So I just want to thank you for that. I think everybody knows me. I'm Susan Buttress, and I'm your chairperson for those who are visitors. This is the second go-round I've had on this. So with that, I'm going to turn it over to Mary Claire to roll call.
So I will call the roll for the members and advisors of the task force. And just a reminder, if you are joining us virtually, just please remember to mute when you are not speaking so that you do not show up on the big screen. So I will start. Dr. Yolanda Barner.
Present.
Senator Hobb Bryan. Senator Nicole Boyd. I see her on the Zoom. Dr. Buttress.
Present.
Representative Creekmore. Miss Randy Carter. Dr. Daniel Edney. Dr. Tanya Fitz.
Present.
Dr. Heather Hanna.
Present.
Miss Biz Harris. Miss Ashton Hotard. Miss Leslie Junkin.
Here.
Representative Kent McCarty. Representative Carl Oliver. Senator David Parker. Dr. Denise Powell.
Present.
Representative Rob Robertson. Senator Robin Robinson. Dr. Casey Stratton Gackey. Miss Candace Taylor.
Present.
Dr. Courtney Walker.
Present.
Miss Tricia Wilson. We do have a quorum, and I will announce our advisors. Mr. Mitch Adcock.
Present.
Dr. Kanisha Bennett.
Present.
Dr. LaShonda Carson. Dr. Candace Carter Stevens. Dr. Catherine Cassidy.
Present.
Miss Georgia Graham.
Present.
Miss Sarah Myers.
Here.
Dr. Julie Parker.
Here.
And Dr. Kenya Elizabeth Wolf.
Here.
Okay, great. Thank you again. Okay, our next item on the agenda is to consider approval of our June 10th, 2024 meeting minutes. And I believe all of you received that. I'd like a motion to approve unless there are any kind of corrections or additions. Okay, we have a motion to approve in a second. So all in favor, if you would just raise your hand, please. Yes. Any opposed? Okay, minutes are approved. Okay, so the main portion of our agenda is truly to go over reports from each of our work groups, and we do have an approval from work group that we'll have to come to in a few minutes. So each work group member has about 10 minutes to present, and then we'll take a few minutes for any questions. So 10 to 15 minutes for presentation, 5 minutes for a Q&A, and let's try to hold that so each work group will have the allotted time that they need. So first on the agenda is Dr. Heather Hanna, who's chair of our Implementation and Service Delivery Model Work Group. Heather, I'll turn it over to you.
Okay, thanks. I'm going to share my screen. I do have a few slides that I want to share with you. Okay, can everybody see that? Great. Okay, so we have been busy bees. Oh gosh, I'm sorry. And we had a 2-meeting retreat. The first was a virtual meeting, and the second was an in-person full-day meeting in Canton. And really, our goal was just to try to make sure that we were all working with the same definitions and understandings about what our task is. And so we started off just by reviewing the mass of information that's been collected to date. And one thing that we came across is that we were really using the term service delivery model and implementation model to mean the same thing when they're really two different things. So part of our work was to tease that apart. And the way that we're thinking about a service delivery model is that this is how the services are delivered. And so there are 3 that are put forth by the Early Childhood Technical Assistance Center as being evidence-based. And the Department of Health currently uses one of these, and TK Martin currently uses one of these. Both can be very successful. Any of these can be used successfully. States do not have to have a single service delivery model. You can use more than one. So our group really decided that we would let this, rather than picking out a single model for the state, that we would let it really depend on a particular region and what their strengths were, and rather to emphasize provider training on best practices and making sure that we are achieving quality indicators rather than dictating exactly how these services are delivered. And what we realized is really our task is more about identifying an implementation model, which we're defining as the overarching early intervention program structure. And this really involves the organizations that are to be considered a part of the early intervention program, how the governance of those works, which service providers cover which areas in the state, which entities perform different services, how kids move through the program, information flows, etc. And this is where we really have been focusing our efforts. Sarah Myers came up with this neat graphic for us, and we've been discussing several implementation model types throughout this task force process. But we realized a lot of us are new, and we just wanted to make sure we really gelled and were on the same page about what these different models meant. So we have the traditional First Steps model, which is a centralized model that a lot of states use. And it means that the lead agency not only administers and monitors the programs, but it also receives referrals, conducts the intake and evaluation, coordinates services, and contracts with providers. Another model that we see in states is called a hub model. And that's basically where your lead agency still administers and monitors the program, but the referral and coordination and all the other pieces are contracted out to hub organizations in different regions of the state. And then we've also talked about a hybrid model, which is really a combination of these two, where based on where a family lives in the state, They might receive services from the lead agency, or they might receive services from one of these hub organizations. But regardless of the model, your lead agency is always in charge of administering and monitoring the program. So we broke out into small groups to try and discuss what we think, given that body of information we had pulled together and our shared understandings about what our task is and what we want to try to put forth as recommendations for an implementation model. We broke into groups to discuss that. And we came back and we had a full group discussion and looked at our themes across our breakout groups. And it was pretty unanimous in that we're interested, within our work group at least, in pursuing and fleshing out a hybrid implementation model where services will be delivered by both the lead agency as well as hubs, initially at least through our current identified university hubs and potentially other organizations who might meet the criteria. Again, you would have that strong monitoring by the Department of Health. We did talk about the need for an RFP process to ensure the capacity is there for any organization who wants to serve as a hub model. And Delta Health Alliance was mentioned across several of our groups as a potential hub because of the location and the capacity there. They have not been approached, but that did emerge as a theme. And then we talked a good bit about making sure that whatever model we recommend, that there is adequate financing for it. And I know our billing work group will talk about this a little bit more, but just the need to make sure we have our Medicaid codes and that we're blending and braiding funding across agencies as much as possible, and even potentially using special funds such as lottery funds as an option. So, based on the fact that we seem to at least verbally coalesce around a hybrid implementation model, we had an anonymous vote within our work group to ask people to what extent they agreed or disagreed with recommending a hybrid implementation model using universities and other organizations as potential hubs. And our responses had the potential to range from strongly disagree to strongly agree. And you can see that we were at a 4.9 out of 5, and that we did strongly agree that we wanted to move forward with this recommendation to you, the full task force. And just to make sure that we were very clear on what that meant, we asked the follow-up question: to what extent do you agree or disagree that the hubs manage referral, service coordination, and service provision with strong monitoring from the Department of Health? And again, we saw the agreement, with 4 being agree and 5 being strongly agree. We came in at a 4.5 across our group. So based on these responses, our work group is recommending to you for a vote that we do flesh out a hybrid implementation model using the existing capacity of universities and potentially other organizations, if they meet the criteria, for referral, evaluation, service coordination, and service provision, with the strong oversight from lead agency and Department of Health, who would also provide these services as well. And again, it would just depend on where the family lived as to who would provide the services. If you guys agree with that, then we see our next steps as being to put these elements in our full report. And that includes division of responsibility for all these different functions among the lead agency central office, their regional offices, and the organizational hubs, as well as division of responsibility for the Part C requirements. There are a lot of requirements, some of which the lead agency has to fulfill, but some that could be addressed at a more regional level. Working out information flows, reporting, monitoring requirements, first step staffing and processes would have to change if we go with a model like this. If we were to recommend it and they were to adopt it, they would need more staffing for monitoring and oversight than that they currently have. So there's some considerations along those lines. And then we have a lot of EI policies that are discretionary at the state level that we can examine as well and see how those are working for us. And Department of Health has just been wonderful to work with and collaborate with. And I feel like we have such a strong partnership moving forward and thinking through what a model like this could look like. We would want to think about what the requirements and expectations for those hub organizations would be and how they might be phased in. And we want to present some considerations for a service delivery model, but again, we don't see that as the primary focus. And we spent a little bit of time on how to address early intervention provider trainings and shortages. And so we see it as part of our purview to potentially put forth some recommendations along those lines. So that is where we got. That was a lot of information really fast, but I'm going to turn it over to Susan to let her take a vote on whether you agree that we should move forward to flesh out this particular type of model.
Right. So before I put this forward, I just want to say Dr. Hannah did a beautiful job of organizing that retreat meeting, and there was a lot of great work from everyone there. And I just have to give you all kudos for that, but particularly Dr. Hannah for that. Okay, so I will need a motion and a second to adopt the work group recommendation of a hybrid implementation model using the existing capacity of universities and other organizations as potential hubs for referral, evaluation, service coordination, and service provision from the lead agency, the Mississippi State Department of Health. So do we have a motion to adopt that?
Denise Paula, I motion to adopt that.
So we have a motion. Is there a second?
Tanya Fitz, a second.
Okay, so let's have a vote. All those, is there any discussion before we go to a vote? Any questions or discussion? I see or hear none. So let's go ahead and go to a vote. And do you want to do that by roll call, or do you want to just have what would be the best? Voice vote. Okay. So all those in favor, those virtually, why don't you just raise your hand if you're in favor, and we can do the same here. Okay. Any opposed? I believe it's unanimous. Leslie, your hand is still raised. That was, yeah. I thought you were raised for in favor. Okay. Thank you. So that motion passes. So upon the approval, the work group will further explore what's needed to make the model work. And so I know the work's not done, but we have permission now to move forward with the delivery model in the hybrid fashion. So thanks, everybody. That was wonderful. Great step. Okay, next on the agenda is our billing system and financials resources needed work group. Dr. Fitz, who is the chair, I believe, is going to present.
Yes, let me share my screen too. I have a small, tiny PowerPoint. Hang on. Well, I am usually really good.
It's happening.
I was like, I'm usually pretty good about sharing slides and stuff. Okay, well, this seems like not my usual. Well, I appreciate everyone for joining it. Okay. All right, here we go. So, I appreciate everyone's input, especially our people who are very familiar with billing um and CPT codes and all of that. So we had a robust meeting a couple Fridays ago, where we discussed the possibility, because we were tasked with that, of the pay and chase model. And the pros is we feel like it would be a simplification for billing for providers and their hubs, um, where that would attract more people because of the simplification. Um, and but the cons really are at this point outweighing the pros, because there has to be a bank of funds provided. Georgia tried this a few years back and failed because they didn't have an adequate funding. Now, any funds that we put um, into early intervention has to be level funding, and we did not feel like the initial bank of funds would necessarily need to be repeated year upon year, and that would be a big barrier for getting that going. Again, there would be a whole setting up of a system at MSDH where with software and personnel and a pretty complicated way of going about this, and we didn't know that we would necessarily have time this year. It may be something that we can pursue in future years as we kind of work on the model of how we're going to provide services. And we had a great discussion on that. And then we kind of went forward from that to like, then if we can't do this pay and chase model, even though we can't, we're looking at how we're going to get the teams, whoops, how we're going to get the teams prepared and paid in a way that would be sustainable for in a business model. So we're looking at different other states and the bundling of their codes for the evaluation, bundling codes for services with different modifiers on those codes. So if a child only needs speech or only needs physical therapy or occupational therapy, or if they need all of it, how we signal that that's being done. Also, has been brought up that we need to work to get professionals that are part of the team that are not traditionally recognized by health insurance companies paid for the valuable work that they do. How do we get our service coordinators paid and our family teams paid, so that we do have access to those people, and that we were going to have to work across the spectrum with both Medicaid, where Medicaid did come to our initial meeting, and private payers to ensure simplicity in the system. By doing that, should also attract more people who are willing to provide early intervention services. And the other issue that we have also raised is to reduce the prior authorization burden. Many of the providers that were in part of our meetings were like, well, this insurance does this and this insurance does that. And at the beginning, when Medicaid had MCOs, this one did this and that one does that. And so working with Medicaid on having some standardizations and possibly adding a modifier that triggers the MCOs and also possibly Blue Cross Blue Shield. We have to bring them to the table and say that this service is related to EI and has been this, client has already been determined to be eligible for services. And those are the things that we are working on within our working group, and we'll have more firm recommendations in the future. Sorry to be kind of brief.
Can I ask a question? I'm sorry.
Yeah.
So Dr. Fitz, when you say team model, is that referring to the hybrid implementation model? Okay.
Yeah. So, as we know, we're not providing, like, when we go into the hybrid implementation model, there should be like a whole team of people, right, that are working on this one case. There should be the service coordinator and whichever therapist and the evaluator, right? I'm getting this right. Am I right with Dr. Hanlon?
Well, yes, after the evaluation, the determination is what services are needed and then who will be the lead. Yeah,
Implementer, right?
right.
And there should be some wraparound services that are often not happening. Am I correct, Dr. Buttress?
The case coordination piece is not always implemented across the state as it should be. And I'd love to hear some feedback on that. Amanda, if you have any, Anna Lynn, if you have any comments on that. But I think case coordination was one, or care coordination was one of those issues that in some cases is not billable through only the health department. So some question about that.
Right. Is she there with you, Dr. Buttress? Can she
She's right
speak?
here. She's gonna speak.
Maybe. Okay. Can you hear me now?
Yes.
Okay. So the service coordination is, there's no billable codes of which we are aware right now for service coordination and that type of care coordination. However, the health department is able to bill for targeted case management for coordinated care with early intervention, as well as other home visitation programs within the health department.
So the hope is, as we move forward, that care coordination would be something that could be billed by the different hubs.
And as well as special instruction, I'd like to put that out there.
Yes, absolutely.
Yeah.
Thank you.
Okay, so the codes are special instruction, care coordination, and then Dr. Walker also put in here. The billing codes that we do have currently for interprofessional consultations are also currently not covered by Medicaid or and I can't speak to if they're covered by private insurances. And trying to get those also covered so we can hopefully kind of piecemeal these together. What's been done in New Hampshire is that they do have a bundled code for that covers what would typically be covered by a full evaluation. And they negotiated prices for that and payments for that. So we're in the midst of working on that. Yeah, and developmental evaluations should also be part of this code. So there should be some psychological developmental evaluations as
So-
part.
I have a question about I guess the team-based eval, because as far as I've understood it, it's so hard or almost impossible for a speech pathologist to bill and an OT to bill, for example, for the same evaluation. And I think there's a lot of paperwork beforehand to get that, like a speech pathologist approved to be able to bill and for that eval. So is there, and I don't know this, but like, is there a way through that, or is there an overarching billing code that would cover the time of all of those professionals? Or would that just be something that the health department could pick up for the evaluation piece so that the individual providers don't have to worry about I don't know, like the nuts and bolts about getting reimbursed for their individual time for that evaluation?
So that is one of the things that we're looking at because there's some T codes or CPT codes that start with T. The G codes are generally for Medicare, but the T codes are for kind of can be used as a bundle with depending on the definition. So those are the things that have worked successfully in New Hampshire. And we're looking at other states to see how they are implementing their billing services and anything that we can do to simplify the process. Even though I don't think it's feasible to do pay and chase, and simplify the PA process so that we're not, if the whole entire EI team, which should include a speech / OT / developmental screening, if that has been done, that we shouldn't be getting pushback from insurance companies and MCOs that this is a needed service. Like, we shouldn't have to fill out 8 pages of paperwork and provide 10 pages of notes for them to deny us and have to go on to a peer-to-peer. I mean, that's why people this is one of the reasons why.
Right. And if I can make a comment, I was speaking to one of the physicians who's over CMS in Arkansas, and he made some comments that were just astounding to me, how much therapy service is being given in Arkansas. Now, frankly, I think that it would probably break the bank if we tried to do what they are doing at this point, and I think they're trying to get a handle on it. So perhaps if there is a simplification of the prior approvals, that there might be a limit. For example, for theirs, greater than 120 minutes a week has to go through an approval process to put. I wonder, what do you think about that, Dr. Fitz? If there might be some sort of boundary where
Right.
there would be an automatic approval until that.
Well, and they renew each 6 months, right? So we have to reeval every 6 months. Is my understanding, right, Dr. Buttress?
I'm sorry. Will you? Thank you.
From Molina, it's 12 weeks, not always 6 months.
I can't hear her.
So Melina is 12 weeks, not always 6 months, and that is very burdensome. So again, back to the statement about standardization, I'm sure you plan to put that in your recommendations, right? That,
Right.
yes. And then I have a question. I don't have a lot of information. I know from the past, private insurance companies, not Medicaid or their MCOs, private insurance companies traditionally, particularly our largest provider, does not cover services very well. Is that still correct from your research?
As far as I know, that's still correct. Like, our largest Blue Cross Blue Shield, depending on, every person has a different plan sometimes, is limiting all therapy services to 20 visits a year. And that's all of them. So 120 hours a week would never be paid for by that provider.
20 minutes, yeah.
20 minutes, sorry, 120 minutes a week. Because that would be eaten up in 4 weeks, really, 4 to 5 weeks. And as far as I've known, that they've never, and most private paying insurance companies never pay speech for language. They'll pay it for dysphagia, but not, or a motor dysfunction, but not necessarily for language. But someone else can correct me on that. But that's my understanding, having done this for.
There are some other plans that also have a lifetime. So that if we're talking about early intervention and this child is just starting out, they have a lifetime number of visits. So if they get to a certain point and they use them all up, then they can't have any more from that. So, yes.
Right, so the child who has the more significant problem needs 3 therapy services would max out their lifetime benefit pretty quickly.
a lot of times speech is separate from occupational and physical, so if they need both, then they run out of that quicker.
I think it's a giant bugger. Like we're gonna have to work really hard to work together to make this happen. So we've got further meetings planned, so we'll keep going.
Any other questions? Mitchell Adcock, Mitch, I know you've done a lot of work and a lot of help with this. Do you have any additional comments at this point?
We had talked to several folks and just working out the billing problems, and a lot of that's going to have to be done with private insurers and with Medicaid. So a lot of it's going to have to be communication and resolution, and hopefully before the session, so that if there are any problems with it, it can be worked out and presented as legislation.
Hey, Mitch, can you also speak? Do you happen to know which plans have lifetime maximums?
I think every one of them are different. I think that's,
Just-
part of the sales process of private insurance. So just what I think, getting the insurance commissioner involved in this to help get a list and what those requirements are and anything that may need to be done to address what's needed.
Right. Okay.
I'm looking, there are a couple of other questions. Courtney mentions, Dr. Walker, that there are existing codes that could be used, 99446, 99449. Are you talking about care coordination?
Those are
Dr.
the interprofessional consultation codes.
Right.
And I think overall, that was one thing that was pointed out is other states use other Medicaid codes, billing codes, and they're usable in this state too. There just has to come to an understanding of what codes are available, which ones should be used, how they should be billed. And part of that's communication and working out, between the health department and providers and Medicaid and private insurance. Because right now it's kind of haphazard. They have a list, but also individual providers use other numbers. And so the number that are being paid by Medicaid are different than what being used through the Department of Health. So bottom line is it's very confusing. Everybody doesn't understand what needs to be used or how they need to be used.
And we'll say one thing Dr. Powell put in the chat, and this is very interesting to me because I remember hearing a lot of discussion about that, and that's using social determinant funds within Medicaid for different types of miscellaneous things Dr. Powell had put in to stand in for care coordination because it can be used for things like transportation and so forth. But I think there is some looseness around that could be explored.
Senator Robinson.
Thank you, Chairman. I'm just, I guess, critical in my point of view would be the coding to make sure that the codes reflect the cost and the costs that are contained within those codes are the same. And as we look at that, then we can track what certain things are costing. So I think coding is critical, especially when you're going to talk about funding with the requests. So if I could say anything, coding is critical, then we need to get that right, correct up front.
Absolutely. Thank you. I just want to make another comment. My colleague from Arkansas, who I was speaking with this morning, made a comment that basically Medicaid is covering the EI cost. In our state, from what I understand, and maybe Annalyn, you have another comment, or Dr. Brooks on this, I see you on remotely, that in our state, many times providers do not bill Medicaid, even though the children have Medicaid because of the difficulty of billing. I will also say, as we've mentioned this over and over again, many of these children who aren't formally receiving early intervention services are receiving services because the providers have circumvented EI and just now go to private providers who then bill Medicaid. So what we are trying to do is get these services organized so that there can be good oversight. All of our children are getting good services. And we can prove to OSEP that our children birth to 3 are getting services. And that's why we are in the needs intervention area. It's just not clear. So again, I know the burden goes back to Medicaid, but we have that match money with Medicaid, which we don't with early intervention. And so to try to keep that in mind as we're moving forward with the billing. I think the comment in our chat has been too, a lot of these codes are not turned on. They're available, but they're not turned on in Medicaid. So any other thoughts or comments?
And I would say to the senator that's near you, Dr. Buttress, is that once the codes are turned on, that is set by the codes are valued by CMS through an RVU process. And not that we have much control over that here, but there is an RVU process. And if we turn those codes on, we can go to some tables and figure out the cost beforehand.
Dr. Powell, I'm reading your comment, like a template we send out to providers throughout the state.
Yeah, I was just saying it sounds like there's a lot of different variations of knowledge around coding and what we could add on for additional coding. So just having a running list, and then if things get turned on as well, we can add that to the list, just like a running, even Google Doc or something like that. Because it sounds like we all have just different levels of understanding of that, from what I'm hearing anyways.
I think you're right. Thank you.
And I would say that when I was reading some of the letters back, especially the one to Tennessee, there was much praise from the OSEP for their training. And this is something that we could definitely use the MSDH to have training sessions on billing and coding, and to make sure that all the providers that are in the system now know what they should be billing and how they should go about doing it to make things much easier.
Thank you so much for your work. I know this is a tough area. Any other questions or comments before we move forward? Okay, I see none. So now we'll move to quality control and oversight of the First Steps program. Dr. Powell, you're up.
And sorry, I'm trying to share the PowerPoint. Let's see if I can get it this way.
While you're getting that up, if we miss any questions in the chat, please send those to Mary Claire, and she will make sure that we put them in the minutes and address them as we're moving along.
I wonder if I might just say this out loud because I'm having a bit of issue with the PowerPoint unless someone else has access to the one I sent and could pull it up.
Mary Claire said she will get that up. If you are okay with starting in the sake of time while she's getting that done for us.
Awesome. Okay. So we're the quality control and oversight of the First Steps Program Committee. Our goals, just as a reminder, were to assist the Mississippi State Department of Health in determining its role as lead agency for First Steps, and then also determining what kind of quality control and oversight is needed from the MSDH to support the program, So this falls under the purview of additional staff, new policy and procedures, or guidelines for service providers. So moving on to the third slide, just for updates. Our upcoming meeting is August 28th for anybody outside of the task force who wants to attend. One of the other things that came up within our meeting as an upcoming task or event was the Medicaid technical bill. And we just brought this up as a potential point of advocacy for us. For background, it must be renewed every 3 years. And the reason this is important, we felt, was because it would help with a lot of the quality improvement in that it would reduce paperwork for parents of children, especially those with severe disabilities or delays when applying for Medicaid. And then we talk a lot about reimbursement. So this ties into that, in that it would increase reimbursement rates for providers, centers, pediatricians, and then really any other services for patients diagnosed with autism. Of note, each year we do bring it up within the legislative session, so there is a lot of discussion around it, but I think this would be something we could advocate around. So on to the next slide, more related to the task force. We discussed a few issues that we felt were tied to our goals. Number one, we found that there were few providers, I think we all know this, for serving large geographical areas and especially being spread thin between counties. One area that really came into discussion a lot was Vicksburg and surrounding areas, but we know throughout the state there are many other areas that have similar circumstances. And the reason this is important is because we have a less regulated system and a combination of referrals through First Steps, and then also seeing therapy services within other parts of the state that are being combined with the programs. So I felt this really tied in with the discussion previously from Dr. Heather Hanna really well. Just when we were talking about, this further supporting the reason why a hybrid model would be useful. And so we could partner with the community therapy services and really create more of a regulated system throughout that, and really support teams so that they're not becoming overburdened and having to travel far to provide services as well. We did see that becoming a Medicaid provider is a pretty difficult hurdle for several reasons, including what we discussed before, which was the low reimbursement rates. And I do think, our discussion about coding and modifying that will be helpful. And then we also talked about job openings and finding, the therapy services and other people who are really crucial in this. We're seeing that there are really long vacancy periods for job openings, which, really plays into the lack of adequate providers, serving populations. And so one of the things that we discussed was that the job can't really be advertised until the vacating period. So you're seeing a lag time. And then often there's 3 to 4 month gap periods of hiring for one position once it is vacated. And a lot of times that's actually a longer period. That's just what we're seeing often. So one of the things that we discussed as a solution was changing the name or changing the framing of the position to broaden the pool of candidates. So we're not kind of like tunneling into more particular candidates. And so that really takes us to really our last slide, which is solutions. And so this is just a few of the solutions we discussed, and we're definitely open to further discussion around this today. But one of the things that came up was virtual services. We know that, a lot of providers use telehealth, but we feel like maybe we could utilize this more within the First Steps program. And this could at least be used within the screening process. So we know that, at least from a pediatrician standpoint, a lot of times it's like going off of chats, SWIC forms, however you're doing that developmental screening. And then after that, maybe some more of that could be done virtually, especially if it's paperwork dependent, screening guidelines dependent, maybe something we could do to help both with parents and providers so that they're not having to travel as much, not having to really build into that burnout, and creating a more sustainable system. We know that from prior meetings around this, that the Office of Special Education Programs, or OSEP, does have guidelines around this. And so it would require us to really know those guidelines well and be creative. So although we can't have mobile teams, we can be creative and use the natural environments within the community as meeting points if we did want to do something in addition or outside of virtual services. So it could be, having a meeting point at churches that people already go to within the community, libraries, you name it. We also agreed with Dr. Hanna's proposal about the hybrid hub system model, just because this is very convenient. It has credentialing already built into the system, and there's a lot of already existing satellite clinics and education hubs. So we mentioned Mississippi State's TK Martin Center. Here on the coast, USM has a really big program, the Children's Center for Communication and Development. And I also wanted to just bring in kind of like, if we're trying to build this, maybe a tier system. So here on the coast, at least, USM tends to take our kids with more complex needs. So off the top of my head, I think of a lot of kids with like global developmental delay, nonverbal, a lot of equipment. And then that way we're not overburdening, you know, the college systems or the hybrid university systems as well, because I can definitely see that trickling down. The other thing that we brought up was following up on insurance impacted credentialing for contractors. This is something I don't know as much about, but definitely would like to explore. So the conversation was that theoretically, if you were credentialed by one medical system, your services should be accepted by all medical systems. I hope I wrote that and understood that correctly when we talked about it. However, insurance companies state you have to be contracted with them for credentialing. So you're seeing kind of some loopholes that we really need to work through to make that easier for contractor providers. The other thing, and this ties into what we talked about earlier, was retention and sustainable hiring. And we talked about communication and marketing being a big part of this as a solution to obtain and keep new providers. And I know we have a work group that's already working on this, but just brought it up within our task force as well. Another thing to think about is centralized strategies for job postings. So we're not kind of like piecemealing in different places. And of course, we know that a lot of the job marketing goes through the Mississippi State Department of Health, but also thinking about conferences, state and national organizations, and then of course, outreach coordinators and potentially volunteering as well within our task force. The last thing that kind of briefly came up and we definitely wanted to talk more about was how do we really ensure that quality is being upheld? And I think this is something that's going to be discussed more in the next meeting. But one of the things that came up was chart audits just to make sure that throughout the state, a lot of our therapy services are all getting the same quality of care, despite the geographical differences and despite the spreading out of services. So those were the big things that we talked about. I think there's a lot of overlap with other task forces. And if you want to, we'll have our next meeting later in the month.
Thank you, Dr. Powell. Again, we really appreciate the hard work. Are there any questions?
I have a question. So your solution for the lag time for hiring. So like if that's being done through the Mississippi State Department of Health, I understand that early intervention, they are, you know, beholden to that process that's kind of at the agency level. But what you're suggesting is an open job title like EI provider, so that whoever applies to it could fill a number of those qualifications. But okay, that's pretty smart.
Yeah, and I think it depends on the job, to be honest, because I'm sure that can't be done for everything. But I do feel like it's better to have someone who meets some of the job requirements and maybe doesn't fulfill all of them, but can learn on the job, as opposed to not having anyone doing that job at period for months.
Mm-hmm.
Do you think that would be possible, Anna Lynn?
I think that would be up to the State Personnel Board if it relates to MSDH hiring. Now, as it relates to our providers, our speech, our OT, those are all contract and subject to the internal MSDH contract process.
Any other questions? I have a question. Apologize for this, but I want to go back to the billing for a minute, if we can. And we had talked about centralized billing not being something that you think would be effective. There had been some discussion, Dr. Fitz and Mitchell, about perhaps a hiring entity. Are we thinking that each hub or the hybrids would all take responsibility for their own billing system? I think I want to make sure that we're continuing to work toward taking the billing responsibility away from the individual providers. That seems to be hugely burdensome.
It is. The only issue that you have to address is the ability of MSDH to handle the billing for everybody. And the issues of whether Medicaid or private insurance would accept billing from the Medicaid, from MSDH for a provider who's not an MSDH employee or structure. So there's a lot of questions that have to be addressed, and you know, cost being a major one, and ability. Because I'm kind of assuming that MSDH right now does not have the staffing or the ability to take that on themselves. And they can answer that better than I can.
This is Ms. Harris. Dr. Buttress, I am remembering that also, though. I do remember that we had a conversation in the billing about should we move on with a hybrid model that potentially it wouldn't just be MDHS, but it also might be each hub might also take on the billing for that region. So I just wanted to, I remember that conversation. I do not remember, thank you, Mitch, for that point about MDHS, but I just also remember us talking about the hub potentially taking that role on as well.
Yes, Annalyn.
And I don't want to speak for Casey since she's not here, but one of the things we have been discussing, since it is a pilot, is looking at what a billing, if they were a hub, looking what a billing process would look like for the hub, so that we would have that information available before the legislative session. So we have been talking about that between us, what it would look like for them to bill versus us. As you know, with the TK pilot program, they're not billing anything because it comes, the funding comes directly to them. So we are looking at that.
Okay. Thank you for that.
All conceptual.
Right. Still some work to do.
I just wanted to just throw this out there that, you know, I think maybe something to consider is that each hub may be more or less likely able to bill. So UMC, for example, if we were to be, that'd be easy because we have that infrastructure put into place. But I don't think Mississippi State, as a university, does not have a credentialing or billing office generally. So that would need to be developed at the institutional level potentially to support that kind of thing, or funding would need to be factored into each hub to be able to support somebody to do that process for the institution. I just wanted to throw that out there.
I would also add to that we are talking about billing, but before you can bill, you have to be credentialed. And so that's another piece of it that would have to also be considered, is that credentialing for whoever is going to be that provider. That's a job in itself.
Right.
And this is Dr. Fitz. And also in this day and age, you need some sort of electronic health record to generate the super bill after you've done your note, to generate the super bill, to generate the billing. And then that will electronically go to through a clearinghouse to, you know, wherever, to Medicaid, or if you are generating it to as the primary payer to be another source. That's also an issue in smaller hubs where people may not be able to afford like the biggest, nicest system. Would they then be able to have access to, like, say, I know the health department does have some access to Epic for some things. And then what kind of, you know, standard EHRs and where are we going to point that billing? I think there's a lot of technical stuff that we haven't gotten into the weeds yet with.
So Dr. Fitz or Mitchell, do you have any information on perhaps a private billing entity that the hubs could contract with to help with that? I know that happens in other states and private practices.
It does. For the state, though, you would have to go through a RFP, you know, solicitation for services. You may could get an estimation, but you know, those services are pretty expensive, but I mean, that's something to look into.
Right, Susan, usually they charge you a percentage of your billing and collections. It depends on how your contract is written of how they get paid for their services as a billing company.
I just wanted to, this is Sarah, add to the discussion. I appreciate Dr. Fitz bringing up the, the options as far as billing and electronic health record systems, because I think that is going to be pretty crucial here as we talk about hubs taking on these large areas and hopefully, ideally being a connector with that independent provider who's out several counties away, right? So we can help them stay on board. I wanted to, I guess, ask a question about, because I thought maybe at the last year's task force meeting, we talked a lot more around a one-time influx of funds. And I know, Dr. Fitz, you mentioned something about obviously, being able to do a maintenance of effort. And I'm just curious if there is an option here that we still need to kind of flesh out for one-time funding that does not then require regular funding at that level. Like, is that still on the table, or is that absolutely not how this works?
Peer actually did some, and Mary Claire, I'm not speaking for you, but they saw one-time funding expenditures for expansion of whatever that doesn't require continued match year after year. So I think the feds if they understand that, and there's provision for that.
Thank you, Mitch. Yeah, I'm just curious if that is still something we want to even look at, if it was on a small level, to see if, because all these things that you're talking about that have to be done, will require a good bit of funding and support from somewhere, whether it be Department of Health or, and so I guess I just didn't want to throw that out if we still think there's an option there for.
Well, and I think we ought to be careful. Again, I'm just kind of trying to help, not part of the task force itself, is if there is something that you guys think will work, will improve services, will improve, reimbursement, more participation, all that stuff. If it costs money and effort, that's still okay. You just have to figure out, kind of an estimate and go into that to get the money or request it from the legislature. But everything to improve the billing system is going to cost something. It's going to include something, changing something up. So, but we just don't know what those numbers are. There's no way to know exactly what it's going to cost, what it's going to be, and the effort, and that's got to be studied a little bit more to work it out to something that is doable. I know I went around the world for that, but it's just not as simple as saying, I'm going to go buy a car, let me go buy a car. It's going to be a process to figure out what it's going to cost you to do that.
Dr. Witt, did you have a comment?
I was just going to say that I do believe, just to say what Mitch said about other states may have done this, and it would be something that we would have to talk with the OSEP about to see what's allowable and what falls within the federal code of maintenance of effort.
And OSEP has been very helpful, so
Very supportive.
Yeah, very supportive. So I think we can reach out to them, Dr. Fitz, and look a little bit further. So maybe after this meeting, we can determine. Somebody needs to mute, sorry.
I put it on the wall or on it, online.
I'm not sure who that is. Would everybody make sure you're muted if you're not talking? Thank you. Okay, so you can see there's crossover in every one of these work groups. So, all right, let's go on to training, recruitment, and other emerging issues. Dr. Walker is our chair, and I believe she's going to present for us.
Can you guys see that okay? Is it on the presenter view?
Yeah, no, can you go back and try to share at slideshow?
What about that? Does that work?
No, now, yes.
I don't have, it does, you just see my,
Yes.
okay, cool. All right, so, yeah, so I'll be providing some updates from the training, recruitment, and other emerging issues work group. And, you know, there may be some overlap with some of the things that have already been discussed. And actually, you know, after listening to Dr. Powell, it's given me some additional things to write down. So I think this is a great way to communicate across the work groups too, especially if we haven't been able to visit with each other. So just some responsibilities of what we were tasked to do. So obviously review the recommendations from the 2023 full task force report, and then provide an update on progress, and then any additional recommendations to the task force to aid the Department of Health in reaching some of these recommendations. And so we have met twice so far, all virtually, and our next meeting is actually scheduled on September 10th at 12:30. But I want to highlight that it has been very helpful working with the early intervention program on this, because they have provided multiple updates to us on all the things that they have already been working on per the task force recommendations. And so, you know, I'll be covering some of the things that they have already started to address in relation to our recommendations, and then some additional areas where we could provide some additional information and recommendations and support to them to help meet those goals. So thank you, Early Intervention and First Steps, for being such a good collaborator on this. So I'm very practical and detail oriented. So I'm just going to go actually through each of the recommendations that we were given as a work group, and just provide some thoughts, some updates on where we're at and how we're kind of envisioning our next steps. So finding number 6 from that task force report included a recommendation that the Department of Health should work to improve recruitment, development, and retention of highly qualified personnel and service providers. And in our conversations as a work group, we identified that there are some areas of training that are needed by new and existing service providers, generally around early intervention services broadly. So there is a need for that sort of training, as well as some additional training. So for example, billing that's come up in this conversation. But it seemed like most of the training on the onboarding for providers has been mainly around how to use the Mighty system and how to document and how to do that. And that didn't seem to be working for some service providers and wasn't helpful because they thought that they could just learn how to do that on their own, but they needed more nuts and bolts of some of the other things. And so we have discussed that the Department of Health should consider adopting these asynchronous training models, that have already been developed by Dr. Parker and Mississippi State University. These training modules they already exist. And the strength is that they are evidence-based and not only align with existing First Steps EI standards, so the standards that our state has already put forth for providers, it also aligns beautifully with national personnel standards. And, you know, I can, if it's okay with Dr. Parker, can share some of the syllabi for those courses. But the idea is that these courses, they would cover an entry-level position, so the early intervention credential, and then there's a secondary level for EI coaching. And so both of these cover the core foundation of what it is to provide early intervention services. And that also includes, you know, training on IDEA, what is the natural environment, how can we best support infants and toddlers and their families within a supportive, strength-based approach, And so she kind of made our job a little easy because these things already exist. And again, they are excellent resources that just need to be implemented at the beginning of a person's entry point into the service provision for early intervention. So that is something that we will be putting forth to the task force, is that would be a very obtainable thing for them to implement pretty soon. The Department of Health has also let us know that they created and filled a position to oversee training and outreach for service providers and internal staff. And so one of the things that we had actually talked about in the implementation model meeting that I was invited to was even just, coordinating with the state departments of health licensure records, for example, because as far as I understand it, all speech, OT, and physical therapists are licensed through the Department of Health. So there's an existing roster of all available people who could provide these services across the state, and that could help them target more specific outreach for those individuals, particularly in areas that may not have a service provider in a county. So it would give them more access to what that could be, and they could be more targeted in their outreach approach to try and get people involved in the system. The other thing that I think has come out of that is also just a natural discussion for collaboration across all of us that are involved here as we move towards a hub model. Anyone who's involved in universities, agencies, whichever, if you're involved with First Steps in early intervention, to also support these efforts. So word of mouth between professionals goes a lot longer than I think, maybe the Department of Health saying, hey, you should do this. And so if I am talking with an ABA provider and I say, oh, hey, did you know that you could, be a service provider within early intervention and bill the Medicaid rate for ABA? Have you considered that? So even just that word of mouth across professionals, I think would be really helpful for encouraging people to sign up. So that I think would also be a good strategy and would be on us. So the other thing that has been done is that the Department of Education has hired a comprehensive system of personnel development coordinator. That's a big word, but CSPD coordinator for short. They are currently funded through a grant, the Preschool Development Grant. And they, in other states, this person is responsible for kind of creating the training and personnel standards for people providing Part B and Part C services. And so it's great that this person exists and that there was funding to support that. And this person is going to start attending, or has already attended, they may have already attended today, the SICC personnel prep meeting to facilitate collaboration between Department of Ed and First Steps, but in particular with that position. And so there's a lot of motivation to work together with that position, which is great. Any questions about, well, I'm not done quite yet with that part. Some other things that we have discussed. So again, another typo, guys, I'm so sorry. So adoption of the hybrid hub model really would allow for opportunities for universities, agencies, private practices to provide evidence-based training to early intervention based on identified needs. And so one example that has come up is more training on standardized assessments required for eligibility determination, not just what is it, but how are you conducting it? How do you score it? How do you interpret those results? As well as any other areas that may be of interest. So, how to conduct an autism screening or something like that. And so we have talked about maybe the Department of Health considering 2 RFP processes for services and training. So if you're, able to provide direct services and can do some training, fantastic. Or if you're not quite ready to be able to provide service provision, but do have a wealth of knowledge within your agency or your university on a particular topic, allowing applications for training only. So that could be a part of the process. So finding number 7, the Department of Health needs to identify ways to increase outreach, education, and community awareness for the early intervention programs. Again, so there has been that position who has been created to do that. And I do, as far as I understand it, there has been a lot of movement to connect with hospitals, to connect with pediatricians' offices, to share pamphlets, information about how to refer, how to what it is, what services are provided in general. And so there's already a lot of movement on that end. And then again, that goes back to our point about partners and agencies really becoming advocate for recruitment into early intervention first steps. I know that a lot of us are a little shy about that because of how things have gone in the past. And we want to make sure that we are recommending services for our families that will actually be obtainable and quality, and that they'll get the things that they need. But, you know, I do feel, and I think most of us on this task force feel that there is a lot of motivation and movement in making this happen. It may not happen overnight, but I think it is happening. And so we really need to work together to collaborate to also help expand awareness of that as well. Okay, so finding number 8, that we should ensure that services are provided in the child's natural environment. So we have not done well on this metric, and there's a lot of reasons for why I think that why that is. But one of the things that we had talked about was that training modules for people entering into the system need to have clear guidance on what is considered natural environment and what is not. And again, that's already covered by Dr. Parker's modules, and she goes into that. They go into that very clearly so people understand what that means. We also kind of recommend a balance of monitoring and support of existing providers to achieve this practice. So listening to providers about what barriers they are experiencing in getting the child into the natural environment. What's getting in the way? Is it, for example, you know, I'm not quite sure what to do if I'm going into a home that may have some safety concerns. What do I do with that? How do I handle that as a provider? Or is it more about you know, my practice may not allow me to travel for that, and I'm booked and back to back. And so those are, I think we should acknowledge those as real barriers for providers to be able to do things in the natural environment. And we're recommending that Department of Health, with their monitoring, also balance that monitoring with some support and problem solving for those providers who are having difficulty providing services in the natural environment. And then lastly, you know, consider recruitment of providers who are at the gate ready and willing to serve children in that natural environment. This is a core foundation of early intervention. Children learn best when they are in a place that is comfortable, that is familiar, and sometimes that is not a clinic. Sometimes that is in a home or in a church or in a library that is more familiar to the family and the community, and they're going to have a lot more success if services are provided in that environment. And again, that goes back to, you know, training to make sure providers know what that is, and if they are having trouble finding what could be the natural environment, providing a list of resources or areas within their region that could serve as the natural environment so they don't have to go and find that on their own. So resource and referral centers, I'm not sure if that would count. I think you'd have to check with OSEP, but there are plenty of those throughout the state. And those could be maybe a place where service provision might be able to happen and may help them meet that metric a little easier. Okay, so the last finding was that Department of Health should consider expanding eligibility criteria by reducing the percentage of delay necessary to qualify for services, and then add an eligibility category for at risk. This clearly would require additional funding. because that is going to and result in an increase in the number of children that need to be served. And that, I think that is a stretch goal, but it's likely not a realistic goal in its current form. And so with that, it may be that the Department of Health can consider a monitoring process for children who are at risk. So they're not quite to the point where they are eligible for services, but there needs to be a process in place to reassess in 3 months, not a year, 3 months, to see how are they progressing, what are they doing, or is it now time to initiate services, just so children don't fall through the cracks. And so that may take some additional staff effort, some sort of new process. But again, if we're moving towards a more hybrid hub sort of implementation model, that could be something that the hubs are responsible for tracking and making sure that they're following up with those families that they've already seen. And then the last recommendation that was put forth was to increase collaboration between First Steps and other agencies. Primarily, the report spoke to Child Protective Services, and it does seem like there are some relationships already ongoing with CPS and early intervention, but we are also going to suggest that they adopt an evidence-based social emotional screening tool for children who are referred by CPS. Currently, early intervention uses the ages and stages questionnaire only to identify for social for needs, if there is a need for further evaluation, and that tool does not screen for social emotional concerns. It does say personal social, but really that means daily living skills. It's not getting at some of the core things that children who have been in foster care or exposed to trauma may be experiencing. And so, you know, we're going to suggest adopting that. The ASQ SE could be one that they could consider, since they already use the ASQ, and that would help appropriately identify a need for further evaluation for those children who have a social emotional delay, which is an eligibility, could be an eligibility criteria. And then recruiting other providers to serve as EI First Step service providers. So if a social emotional delay is identified, and that needs to be included as part of the IFSP, recruiting clinicians that could provide services to treat and to serve those children and those families would be essential. And so that would include inclusion of mental health clinicians in the system. Okay, so thanks. Any questions?
Thanks, Dr. Walker. I know a lot of work went into that, and that systematic review was really good of all of our recommendations from the task force report. Mary Claire and I were just commenting how good it felt for you to go through that. And I know that several of the members and chairs did a lot of crossover work with each other, and we knew that's the way it would and should work. And I want to again thank everybody who attended multiple meetings over the last several weeks. Any questions about the training, recruitment, and retention? Yeah, and I want to thank again Dr. Parker for all the previous work that she's done. I know her modules were actually placed within the health department, right, Dr. Parker? And Dr. Witt, I think y'all have access to those already.
Yeah, so yes, I have actually been in conversations with Dr. Witt and Ashley both, and we are working on a plan now to, as by the 1st of September, to get participants into the modules. So we're pretty excited about that.
Thank you. Thank you so much for that hard work. Okay, we are a little bit ahead of time, so I might be able to give you a few minutes back, but I do want us to take a minute to talk about what next. Mary Claire and I had talked about a timeline of sort of where we wanted to go with that. And Mary Claire, I've done a lot of talking, so maybe I'll turn that over to you. And we have a sort of a new proposal we wanted to talk to you about, but go ahead and start with that if you will.
Yeah, Dr. Butcherson and I have tried to come to some type of agreement on the timeline so that we have everything done by December 1st. And we were thinking that the work group reports should be due by October 15th. So I know that is a little later than we had discussed at the beginning. But we think if you get those in by that date, we should be able to get everything combined into one report. But first, I want to talk about, after hearing Dr. Walker speak about how it's been nice to have this meeting where you can kind of all get together to discuss what you've been talking about in your work groups. Would you all want to meet again as a full task force, maybe at the end of September? Would that help? And y'all can just either put it in the chat or nod your heads or speak up, whatever works best for all of you. I'm seeing a yes, that would be good. If everyone is in agreement, is there a time in September? We'll get Dr. Buttress to look at her schedule to kind of see what works best and see if that will work best for everyone.
Yes. Let's see. Actually, look at September 23rd on your calendar. That's again a Monday, or not again a Monday, that's a Monday. Or perhaps the Tuesday afternoon of the 17th. So September 17th, 1 to 3, September 23rd, 1 to 3.
Seeing Dr. Hannah said the 17th is better for her.
Okay.
Does the 17th from 1 to 3 work for everyone?
That's a Tuesday afternoon. I know our medical providers may have some difficulty, but if you can't make it, could you maybe send a representative? If not, I'll look for another date. Yeah. Go ahead.
I'm sorry, I didn't mean, so that is the week of the Division for Early Childhood Conference in New Orleans that many early intervention professionals will be attending. I'll be there, and I know some folks in different areas. I think Ms. Myers will be there as well too. And then, so there might be a few people out.
So that's 17. Okay. Maybe we'll back it up a little bit. What about September 12th? That's a Thursday afternoon. I'm just going to afternoons because it seems that those are better. Or September 9th, which is a Monday.
Does that give enough time between now and then to do some more work?
Well, that's
Yeah,
a
get
good
any more
question.
together.
Probably not. Okay. Hang on. Did we look at the 24th of September? Afternoon of the 24th? I forget how late in the month it already is. Goodness. Okay. How does September 24th look?
Dr. Fitz is saying that's good for her.
That works for us.
Dr. Hannah?
She's saying she can join.
Yep. Okay. Okay. Well, let's try the 24th.
From 1 to 3.
From 1 to 3, if you'll block your calendar for that. And we'll get an evite out, right?
Yeah, we'll get everything scheduled.
Okay.
So it's September 24th. And then again, just to go back to when the work group reports are due, October 15th. And then we were thinking that after that, the full task force could meet again on October 29th. And that would be where the work group chairs would present their reports to the full task force. Does October 29th work for everyone?
I'm not seeing any no's yet. Making sure we don't have any big meeting.
And we'll try to go ahead and get that scheduled as well, maybe 1 to 3, 1. And that one may take longer because each group will be presenting. And I mean, if possible, I would think that you would want to attend in person for that one. I know that's hard for a lot of our members. Or Dr. Walker maybe having a baby.
Oh,
Have to
goodness.
get someone to present for her.
Okay, yeah, Dr. Walker, if you could, perhaps, if you happen to be out, maybe we can get someone else to present for you, if everybody else can attend.
And then
Got it.
we
Okay.
may have to have another meeting in November, but we can kind of see where we are and how the October 29th meeting goes. Because if there are no changes to what's presented, then I think we can go ahead and approve the report. But if there are changes, then we will need to make those changes and meet one last time. But again, I would suggest people attend the October 29th meeting in person. And it was just from being at the delivery model work group and all of those people being in person, it really went well. And the discussion was great. So that would be my recommendation.
Right, we agree that sharing session was excellent. So I'm seeing a lot of things in chat. Am I missing anything? Please speak up if I've missed something that you wanted to say. A lot of responses about the date. Okay. Any other issues, anything you want to bring up, ask, complain about? Feel free. If not, I will entertain a motion to adjourn. Coming from Biz, a motion to adjourn. If there's no objection, we're adjourned. Thanks, everybody. We really appreciate you.